Hello, and welcome back to the VJ Hem-Onc podcast. This week's episode focuses on toxicities and adverse events following CAR T-cell therapy, featuring valuable insights from leading experts. Topics covered include the mitigation and management of infections, monitoring for less common toxicities, and factors impacting the incidence of cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome. This podcast is part of the CAR T and cellular therapy focus channel on VJ Hem-Onc, which is supported by Legend Biotech. This supporter has no influence over the production of the content. This podcast is intended for healthcare professionals only. We recently attended the 2026 EBMT annual meeting as an official media partner and interviewed leading experts in transplantation and cellular therapy. First, you will hear from Marion Subklewe, who outlines the main factors contributing to the observed reduction in the incidence of higher-grade CRS and ICANS following CAR T therapy.
Yeah, so the good news is the rate of higher grade in CRS and ICANS has reduced over time. And I think that's closely connected to the risk profile for CRS and ICANS. So there's three factors that are contributing to the reduction in the incidence of higher grade CRS and ICANS. First of all, it's the CAR T-cell design and the CAR T-cell production. So CD28 constructs have a higher rate of higher grade CRS and ICANS versus 4-1BB products. And we are using more 4-1BB products and have more products available. So that is already contributing to the reduction. And then I also like to highlight we have a lot of dual targeting CAR T cells evolving, and they are not only dual targeting, and you could even imagine that they have more toxicity, but often they also have a different process of production, earlier, shorter production, stem-like phenotype, and has been shown so far from the early phase 1 trial data that CRS and ICANS is also going down. So it seems also that the novel constructs will decrease toxicity. Second is we know that high metabolic tumor volume, and that is associated with inflammatory markers, contributes to high-grade toxicity like CRP and ferritin. And we looked using the CAR hematotox, just as a reminder, that integrates neutrophils, platelets, hemoglobin, CRP, and ferritin. It's taken at time of leukapheresis. And if you look at the high versus low CAR hematotox patients, you can see that when we look at now large B-cell lymphoma, fourth line, about 60% of the patients have a high CAR hematotox score, also reflecting high inflammatory markers, reflecting often high tumor volume. Now, if you go in earlier treatment lines, the second line, we only have about 30% of these patients to be high risk. So reflecting that now as CAR T cells move in earlier treatment lines, as we've seen in lymphoma, as we've seen in multiple myeloma, we have fitter patients with lower tumor volume, less inflammatory marker. So that is also contributing to the reduction in higher grade CRS and ICANS. And third, so are the physicians doing anything differently? So there's also data was actually presented at ASH 2024, where 1,600 patients were looked at, treated with axi-cel in third line large B-cell lymphoma over time, comparing 2017 to 2019 with then 22-23. And you can see a marked decrease in the incidence of higher grade toxicity. And I think that is due to our learning curve that we intervene early. So for CRS, often we use tocilizumab already with persisting grade 1. We don't wait for progression to grade 2, so earlier intervention. And the same is true also for neurotoxicity. I think here we've also learned to intervene early. We know that steroids short-term have no negative impact on CAR T-cell function and outcome. And we've also learned that anakinra used at higher dose can also help to relieve symptoms and reduction of higher grade ICANS in a shorter time period. So I think these three factors are actually contributing to our better management. And then lastly, we now also have very good prediction scores. Also, if you think about inpatient, hybrid, outpatient setting. So we have scores developed also by the French group to predict which patients are going to develop higher grade CRS. And the same is true for ICANS. So I think it's a good learning curve and we are treating better patients.
Next, Eleftheria Kampouri shares insights into infection risk in patients being treated with CAR-T, with a primary focus on the early post-infusion period, and outlines potential prevention strategies.
Oh, that's a huge subject. I feel like we tend to think about infection risk in separate phases. Like the first 4 weeks is kind of the early stage where we see lots of infections. During this period, we have patients who have severe neutropenia. They're experiencing all the immune toxicities. They are getting immunosuppression for these toxicities. So we tend to see the highest incidence of infection. And these are up to 2/3 bacterial causes because these patients are in the hospital. They're neutropenic. We do see some herpes virus reactivations during these first 4 weeks, in particular cytomegalovirus, since HSV and VZV now with prophylaxis are prevented. And invasive fungal infection remains relatively infrequent. When it occurs, it can be devastating, but at least for now, it's rare. When it comes to prevention, which is extremely important, we do not have a consensus. There is this great guideline by ACTCT, and we are currently working on the guideline by the SL. And I know there's also work by ESTMID, but so far we don't have a lot of high evidence because we do not have randomized trials in infection prevention. So this is very largely extrapolated from allogenic stem cell transplants and from expert opinion. So I think that, the different strategies that are implemented in different centers, it would be hard to summarize right now, but I think that we are all in agreement that we should be preventing HSV and VZV when it comes to viral prevention with valacyclovir or acyclovir. We do give prophylaxis for pneumocystis jirovecii. In some centers, we do give fluconazole to prevent yeast. And in some other centers, we even may step up to posaconazole to prevent mold. And when it comes to bacteria, I come from a center where we do not give fluoroquinolone prophylaxis. I know that out there are lots of different practices when it comes to that. But for sure, we should be treating the febrile neutropenia when it occurs. So for the early period, I think I didn't miss anything. Oh, of course, the cytomegalovirus, which we could be monitoring for. But I think that we still are in lack of data regarding what the actual clinical impact is to see whether we should be treating when we detect or even if we should be preventing. And then on the long run, of course, we should not be forgetting about vaccination, globulin replacement treatments, but these are mostly for the management of the long-term risk for infection.
We also asked Dr. Kampouri to discuss the management of patients who develop a fever following CAR-T infusion and whether antibiotics should be used in this setting.
So basically, fever is very frequent in the first weeks after CAR-T cell infusion, and this can be due to infection, but also very frequently due to CRS or both. There is no way of telling, but this fever occurs during the period of severe neutropenia. So the cornerstone of the management of febrile neutropenia is antibiotics, broad-spectrum antibiotics. So I think that we cannot really take the risk of not covering a potentially life-threatening infection during the period where the patients are the most fragile. Of course, this comes at the cost. We are all aware that we might be over-treating CRS, even when there is no infection. And this can have a toll both on antibiotic resistance, the microbiome, which we know it's kind of important even for hematological outcomes. But on the other hand, we don't have a lot of other options. There are some very interesting data on how to risk stratify in order to distinguish patients with CRS versus infection. But again, this may not be available or may not be very clinically applicable at this time. So I think personally that our best option would be to kind of discontinue and de-escalate antibiotics in stable patients who have no longer fever, for whom we have not identified a pathogen or a clinical focus of infection. I think our best bet would be to just treat for a short period of time.
At this year's EBMT meeting, a symposium was held to address common misconceptions surrounding CAR-T for diffuse large B-cell lymphoma. As part of this, Birte Friedrichs discussed the misconception among physicians that the side effects of CAR-T are too severe for their patients, noting the potential impact of this belief.
So I think it's important to acknowledge that CAR T-cell therapy can be associated with significant toxicities, particularly CRS and neurotoxicity, but also infections, and that these require experience and management. But I think we have learned over the past years that these events are usually predictable in a certain way. They occur early, and in most cases, they can be managed with established strategies, including now also early intervention and even product selection. So while the toxicities are very real, the perception that they are uncontrollable or even prohibitive for many patients is not really aligned with the current experience. So especially outside of specialized centers, this perception can influence referral patterns. And as a result, some patients who might benefit from CAR T-cell therapy might either be referred late or not referred at all. So I think that's where the biggest impact of the misconception lies, not necessarily in the real eligibility itself, but in access to expert evaluation. So my message would be that this decision about eligibility and the patient to be more sensitive to side effects doesn't have to be taken alone. So CAR T-cell therapy is highly specialized, and the patient should ideally also be evaluated in such an experienced center where the benefits and the risks can be assessed in a multidisciplinary team. And even patients who may initially seem fragile can sometimes be managed safely with the right support. And I would strongly encourage for early referral or at least discussion with CAR T-cell centers before deciding against CAR T-cell therapy as an option.
Earlier this year, we spoke with Megan Melody, who shared advice for community physicians monitoring patients for less common toxicities following CAR T.
Yeah, so I think that all of these toxicities should be monitored in collaboration with the CAR T treating center. And so I think the toxicities you're more referring to are maybe the ICANS, which is like a very robust inflammatory response, kind of mirroring the disease course of HLH, and possibly some hypogammaglobulinemia, and then some these pretty profound infections post-CAR T-cell therapy and bispecific antibodies. And so truthfully, when my patients are monitored post-CAR T-cell therapy, in the immediate setting, so like for the first 60 days, I am checking a ferritin and CRP, and that really does help us to monitor for ICANS. And so as my patients re-enter the community at an earlier time, now with the new updated FDA guidelines that sometimes they're returning home at 14 days, I'm always sending a letter to their treating physician just saying, hey, when you see these patients for blood work or if they come to you, please make sure that in addition to a normal CBC, CMP, LDH, you're also checking a ferritin and CRP. And if these are rising, feel free to reach out to me. It is not our expectation, or at least not my expectation, nor the expectation of the colleagues I've interacted with, that we expect our community physicians to be able to manage ICANS, but simply knowing that it is a toxicity and knowing what labs are easily monitored for to kind of identify this toxicity is essential. And so a rise in ferritin really is concerning for ICANS. Also, we can see some liver and organ dysfunction and some profound cytopenia. So if you see those happening, please feel free to reach out to your CAR T-cell treating center and they will talk you through what to do next. Other things that we look for, and again, this is included often in my letter when I'm sending patients back to the community, are things like profound cytopenias and profound immunocompromised state. And so again, with each blood check, for the first 60 days, I'm typically monitoring blood work every week. If patients really recover well, maybe I'll move it to every other week. But with those blood checks, like I said, again, we're checking a CBC, a CMP, an LDH, and a ferritin and CRP. And when, the other thing that we also are checking for is something called IgG. Now, I'm not checking that weekly, but I'm checking that periodically. So I recommend at least checking it every 2 weeks for the first 60 days post-CAR T-cell therapy and then moving to monthly. And why are we doing that? Well, these T-cell engaging therapies deplete our B cells. So they call B-cell aplasia, and our B cells and our plasma cells are what make antibodies. And so these patients often have really suppressed IgG levels, resulting in profound infections. And so the administration of IgG in patients with an IgG level less than 400 or even less than 500 with recurrent infections has been associated with improved outcomes. So if you're starting to see the IgG level trend down, or you're having a patient, who just can't clear rhinovirus and their IgG is kind of stably hovering at like 495, reach out to your treating CAR T-cell therapy provider. They'll be happy to kind of guide you in this, but ultimately this is most likely suggested that your patient would benefit from IVIG. And, like I said, this has been shown to improve treatment-related mortality and overall outcomes. So I think that it's essential, in making sure that we really help to support our patients. And like I said, there are some long-term toxicities like prolonged cytopenias or delayed onset cytopenias. And so there's ways that we can identify patients who are at high risk for this using the hematotox score. But now there's also a grading criteria for these post-CAR T-cell cytopenias, something called ICAT. And so, there's actually now becoming standardized management for these cytopenias. So if your patient initially was discharged and their platelets and their hemoglobin and their neutrophils are recovering, and now you're seeing them post-CAR T-cell therapy, 3, 4, 6 weeks out and their cells are dropping, again, this is a time to just sort of trigger a reach out to your CAR T-cell treating center, and they can kind of guide you through the management, either through GCSF, transfusion support, or sometimes we're even using like TPL agonists, etc., to kind of help support these patients.
Finally, you will hear from Kenneth Lim, who highlights some adverse events that physicians should be aware of when treating patients with multiple myeloma with the CAR T product cilta-cel.
I think the timing of CRS is also important, because obviously with the lymphoma CARs coming earlier, we have seen the CRS occurring in patients in the first week of CAR infusion. However, what we noted with cilta-cel is that the CRS, patients with CRS tend to occur a bit later. So if a patient who is being infused with cilta-cel comes in day 1, day 2, day 3 with a fever, early onset CRS, that is considered high risk, suggestive of a more inflammatory profile, and patients should be monitored more closely when they come in with early onset CRS. What we found as well with cilta-cel is that the ICANS rates were not as high as the lymphoma CARs. So I think not all CARs are built different, but I think I think most people do not know that CRS for the cilta-cel cohort does occur a bit later. The other thing as well, which hopefully we can get our study published, we did have an abstract last year talking at Tandem and subsequently at EHA 2025, documenting IEC enterocolitis. And what we see is that these patients can present up to 3 months after cilta-cel infusion. And we still do not know the pathophysiology of this, and hopefully there will be more consortium. There will be a consortium sort of collaboration trying to basically document the experiences of different centers with managing this and diagnosing this entity. But I think a lot of people do not realize that once they go home from the CAR T centers, particularly after a month of monitoring, patients can present with profuse diarrhea 3 months later. Well, we have found certain risk factors for that, and then it was previously presented at Tandem. And what we found was that patients who had delayed neurotoxicity within the first 3 weeks, there was maybe about 8 to 10 times increased odds of subsequently developing ISA colitis. In terms of the incidence of that or how prevalent that is in cilta-cel infused patients, we are seeing it at a rate of maybe about 2% to 3% of patients. That's although the risk is small, patients prior to getting consented to receive cilta-cel therapy should be aware of this risk, because it can prove highly debilitating, and a lot of times the symptoms persist and do not resolve.
And with that, we've come to the end of this episode. Thank you for listening. For more updates, make sure to visit our CAR T and cellular therapy focused channel on vjhemonc.com. Don't forget to follow us on X at vjhemonc to stay in the loop, and subscribe to our podcast on Spotify, Apple, or Podbean so you never miss an episode. Until next time.